If you have any confusion about hormone testing for age, stage, type, and situation, then today's show is for you. Leah, hello. So good to have you back.
Thank you for having me. Good to be back.
Oh, I'm excited because today we're talking about a topic that is close to my heart in that I've probably had every type of hormone test under the sun. When you've dealt with a complex chronic illness, it definitely becomes part of the mix. But B, also because in doing so, looking back and speaking with others, it often makes you think, God, did we really need to test for that? Or was that the best kind of testing to be doing at that time? And given your incredible knowledge on the subject and helping people with complex hormone issues, I thought you were perfectly placed to guide us through the wide world of testing when it comes to hormones, age, stage, situation. We're going to try and go everywhere.
Hopefully.
So can I ask you to start? When, as a younger practitioner, and starting to like, oh, but this is what I've been told, and this is when I'm going to test for this, and then when did you actually start to see some areas that you felt needed more clarifying, and where you were starting to want to do things differently yourself? Like that would surely happen in the journey of being a clinician.
I think one of the most fascinating things for me as a clinician is the way I work is I sort of always learn something and then change things clinically and then stretch my wings and then go, no, I want to learn something else. And I sort of do that. So depending on when you catch me, you're either going to catch me in the no, this is where the science is at place versus this is where my instinct is taking me. And I think as a clinician, your instinct evolves as you evolve. And as what I find most fascinating is now I'm 46 and I've got patients that I've had for 20 odd years or whatever. And as we've evolved together, how our interpretation of things has changed and how far I want to go. So the young version of me, 21 out there graduating, it was textbook stuff. It was, this is where the data is, this is what I'm meant to do. And then when you realize that science doesn't have all the answers, you start stretching and going beyond. So that was probably within the first 6 months. But then when you come to the other end of the spectrum, which is where I did a whole PhD on assessing hormones and all that sort of stuff, you realize that we put so much emphasis on numbers that there are so many variables that influence the interpretation and the accuracy of it. We really need to strengthen that clinical muscle more than anything else, because the piece of paper is one thing, but yeah, I mean, just interlab variabilities, let alone different labs comparing, let alone different types of specimens, let alone all the different things, and you get so much different information depending on what you're looking at.
So would you say the most important thing for certainly any clinicians listening would be to be filling in the majority of your gaps assessment and decisions with who you have in front of you and what they're
100%.
experiencing?
100%. 100%. And also trusting that firstly, your patient has a need that science may not have a test for, but also that your instinct of how to help them may actually not have a black and white scientific result that explains how and why what you do works, which is tricky. And so when we're younger, we're not as confident and we go, well, I don't know anything, so what do I know? But then as you get older and you get more experienced, you realize that supporting the patient based on your instinct will invariably give you the outcome, and the piece of paper may not be the guidance.
So with that in mind, hormone testing. So can we go through what we know about various hormones at this particular time? I mean, that's like a 3-day lecture. I completely appreciate
Just
that.
keep it abridged.
Keep it abridged. Crib notes for the Gen X listeners. And the best way to test for those, as has become apparent. And I mean, you could be talking about time of day even, or day of cycle, like go
100%.
as far and wide as you want to on this. But I really feel like people find it very hard to know. And I remember looking at a lab result which said everything was fine, and then thinking, I'm just going to do my own research. I'm that type of patient on this. And then it turns out, for whatever I was testing at the time, I can't remember, but it was a specific time of the cycle that was really important to capture.
Yeah.
And otherwise it would just be completely irrelevant, whatever the piece of paper said.
Yeah, 100%.
Mm.
So let's start. Let me try and organize this as simply as I can. So let's talk about generic hormone tests for men and women, and then
Mhm.
we'll start specifying them based on sex and age and all the bits that go with it. So generically with hormones, there's a couple of basics. Depending on, so the endocrine system, which is our hormone system, got different glands in different parts of our bodies. Depending on which gland produces which hormone, and depending on which hormone you're trying to look at, determines the environment with which the person needs to be in to get the accurate result. So for
Mhm.
example, a lot of the hormones that are secreted by the brain, they need to be seated for about 20 minutes before their blood draw. They need to be not stressed on the day. Some of them, they need to be fasting. Some of them, they need to have eaten. You need to be quite specific about those variables. But you can get, for example, a hormone prolactin. I've had a patient where she sat for 20 minutes and was de-stressed and was totally fine, and a hormone level which was completely normal. I think it was somewhere in the 300s, versus 2 days before, totally stressed, ran in, the phlebotomist kind of jabbed her a few times, 1400. So
Wow.
1400 is, like a clinical pathology, 300 is completely normal. And so the interpretation of the dynamics of how they are, and because the fundamental principle of the endocrine system is that it's a series of dominoes. So if one is out, all of them are affected. So
Mm.
if she fasted the night before, or he fasted the night before, if they ate breakfast, if they drank a Diet Coke, like whatever it is, affects the harmony of the whole picture. So making
Mhm.
sure that you've got, I guess, there's clear structure and uniformity of how you're testing things. That's the baseline for everybody. For men, depending on which endocrine gland you're looking at, realistically, they're generally very stable, except frequency of ejaculation, frequency or intensity of exercise, and sleep will influence things dramatically, as well, obviously, as food and things. But any day of the week, it's generally fairly constant. But obviously, if you're looking at adrenal hormones, for example, and he's rushing to work versus it's on the weekend, you're going to get variations. So just be mindful to ask the questions of where were you? What were you doing? How was the experience of getting whatever sample it is collected when you're looking at that result with that person? And potentially, if you know that they've got a vulnerability for X or Y, coach them around it before they get the sample collected.
Mhm.
Women, on the other hand, it's a much, much bigger, more complicated picture. You've got to factor in her age, her menstrual cycle, if she's menstruating or not menstruating, if she's on any contraceptives, if she's on IUDs, if she's perimenopausal, if she's menopausal. Like 101 things will affect things. And also things like pregnant, not pregnant, stage of pregnant, how old her kids are, if she's breastfeeding, you name it, as well as all the general things. For the average female of reproductive age, when we're wanting to look at her reproductive hormones, we're wanting to look at them on particular days of her cycle. So the textbook definition is that for a woman, you're wanting to look at the bulk of her hormones on day 2 of her menstrual cycle, but you've got up to about day 5 to 7. And that what you're trying to achieve is a baseline of all of her hormones so that there's not a lot of activity for her cycle. Obviously, further along as she progresses in her cycle, everything's going to change.
Mm.
If you know the day that it is and you can calculate the reference range and whatever, you can do it. But in the early stages, just be quite clear on what that is. And then you want to check her hormones 7 days after ovulation. So 7 days after ovulation, if she's a textbook, is day 21, but the average woman isn't a textbook, which means you've got to work out when did she ovulate, and then 7 days later, have a look at it. But for women, her hormones are affected by every single thing she's exposed to emotionally, physically, mentally, dietary, exercise, you name it. If she fasted and did like a detox the week before, if she had a really heavy period and then checked it just after, like so many things will affect it. So it's about trying to understand what was going on for her at the time so that you're quite clear about how to interpret it.
Mhm.
Um, do you want me to go through forms of tests now, or does that sort of give a bit of a base?
It gives a really good baseline, and I think I just want to ask like a deeper question around
Mm,
that piece of like profiling the woman or the man. Like, were
yeah.
you in a rush the morning of? Like, I
Yeah.
don't think I've ever been given a you must be seated and calm for 20 minutes,
Yeah.
deep
No one talks
breathing.
about it.
No one talks about that, and
Yeah.
so I was thinking about the cortisol test. Like I
Yeah,
have been told do that first thing in the morning,
yeah,
and don't like do exercise before it. So
yeah,
I mean, I guess that was a good little add in there, but
yeah, yeah,
that's
yeah,
it. So
yeah.
if you found it really hard to find a park, or someone cut you off in the traffic, or was an asshole, and then you kind of arrive a bit angry with the world and you're readjusting, and that's when your blood gets taken, when you're still in that fight or
Yeah.
flight from having a narky traffic experience,
They'll
that
all be
could
wrong.
be, yeah.
They'll all be wrong. So there's so much influence that's happening from all of the surrounding experiences. And if a woman gets her prolactin again, for example, at the beginning of a cycle or at the end of the cycle, depending on what's going on with her progesterone, completely changes it as well. So
Mm,
it's the specificity of that moment, that day, everything that she's doing. It's phenomenal, the differences that you can see. And I guess I have the privilege of seeing so many bloods from so many people, but also so many bloods from one person,
mm,
when you can start to see patterns for them. And I think that's, to me, I find that's one of the most beautiful things of working with people for a long time. And you kind of go, no, no, I remember when this happened to you last time. This is what your bloods did. That's what this means. And you're both understanding the rhythms of each person, because
mm,
the rhythms are what make us, always in the back of my mind when I think about a piece of paper that tells me where I'm at in that moment. It's a reference range that was based on a reference group of population. And you may or may not know what that reference group consisted of.
mm,
So is it male or female? If it's female, what were their ages? What was their demographic? What was their ethnicity? What was, like, 101 things come into the mind. But the reference range is meant to be a good cross section, but it won't be everybody.
mm,
So it's about trying to get a sense of what's your reference range when you thrive.
mm-hmm. Whew. And
Yeah.
the poor
Sorry.
GP, no, but I think of the poor GP with 15 minutes to see someone for one issue.
How
Um,
can you consider it? You
how can you
can't.
consider it? Then
You
I
can't.
think of the poor government with their medical costs, and
Yeah.
half of these hormone tests would be completely useless. Yet they're paying for them. Like I just think big picture,
Yeah.
we've
We
got
need
a
to
few
change
things
things.
playing against us.
Yeah, we do. And, the limitations of Medicare, if we think about the thyroid, where
Mm,
a woman's or a man's TSH is between a certain range. And we know based on the literature that that range, so TSH, for example, when it's above 2.5, we know that there's a subclinical thyroid condition going on. But Medicare will only cover T3, T4 when it's above 4 or 5, depending on the lab, when they're already in overt symptoms. So the
mm,
idea of integrative, holistic, preventative treatment is outside of access for a lot of people, based on
yeah,
knowledge, based on their clinician, based on, yeah, limitations. It's
yeah.
a hard one.
It is a really hard one. And
Yeah.
so you mentioned obviously the blood is only one small piece of what's going on with hormones.
Yeah.
There's obviously been the introduction of, dare I say, trend
Yep.
towards urinary
Yep.
metabolite testing.
Yep.
How do you feel about that in terms of what it's brought to your practice? And has it added to the picture, or kind of made you see one to be more useful than the other? Any
For
changes
sure.
there now that you've got both in the mix?
Absolutely. Do you want to give me an age group that you think would be best that we talk it through?
Ooh, okay,
Pick one age group because we can translate it to all of them.
let's talk about um a menstruating 20-something-year-old woman
Okay.
without a pregnancy or postpartum picture. Let's try and pick
Good
the least
caveat. The
least
least
co-
complicated, we think.
complicated female stage
No
of
PCOS, regular 28-day menstrual cycle,
yeah,
blanket. Okay.
totally regular.
So totally regular, predictable textbook female. All right. So
Mm.
also remember that all the reference ranges for hormones are based on 20-year-old women. They're not based on
Ooh,
30-year-old women. So just know that.
wow.
So I
Okay.
remember doing the PhD and I was like, hang on a second, but what about 30-year-old women? What about perimenopause? And they're like, we don't have reference ranges for them.
Oh
Mm.
my gosh.
No, we
Still.
don't. We still don't. We still don't. Mm. Yeah. Okay, so average 20-year-old woman, 25-year-old we'll say, because that her cycle's more predictable at 25. So for her, if we go into a blood test on her and we're really specific and we do it at the beginning of her cycle, 7 days post ovulation, we specify which hormones on which days, we do all the basics, yeah? For
Hmm.
her, we'll get a sense as to what's going on because there's a rhythmicity and a regularity. So her cycle, it's usually predictable month to month. So the blood will be fairly indicative of what's going on. We can test for sure anterior pituitary hormones like FSH, follicle stimulating hormone, luteinizing hormone, which we can't test through saliva and urine, but we will also get a snapshot of progesterone, estrogen, cortisol, things like that. And we'll be getting a snapshot of a generic picture of what are the hormone building blocks for her cycle. If we were to test her through urine, so the dried metabolites, what we're getting an understanding of is we can do it a couple of ways. One is where we do her full cycle through urinary metabolites, and we can map the changes and fluctuations through the cycle. But the most interesting day where the reference ranges for dried urine are the most, what's the word? Not accurate, but the most predictable is that equivalent day 21, that 7 days post-ovulation environment. And in that space, when we look at that day, we can get information about hormones that are at a different level. We can get information about hormones that are further along pathways of metabolism. So we can look at things like not just estrogen in blood, which is technically E2, or estradiol, which the ovaries produce. We can also look at estrone and estriol, which are E1 and E3, which are different variants of estrogen. And then we can look at that estrogen and go, well, okay, so we're producing different types through different tissues. How is it metabolized? What are the byproducts? And then what are the toxicity concerns of how that estrogen is metabolized? And that's information that you cannot get from blood. So you get an understanding of what does my body do with that hormone? Where does it get stuck? Where is it working? Where is it not working? And are the other hormones that actually interfere with those pathways supportive or hindering anything that goes with it? In addition to the urine, though, often you'll combine it with saliva. So you can get saliva for just saliva, or you can get saliva and urine in combination, which is my preference, because then you can test things like cortisol at multiple intervals through the day. So that blood level of cortisol that a person can do is interesting, but me at 9 a.m. on a Monday morning in blood is going to be dramatically different than me at 6 a.m. when my alarm went off, 7 a.m. when I'd finished exercising, and 10 p.m. when I'm trying to go to bed. But the saliva gives us the opportunity to see the movement of cortisol through the entire, well, 24 hours technically, but you can do 6. So you can even wake people up in the middle of the night and understand what it is. And the cortisol pattern, or something that's known the cortisol awakening response, or CAR, helps us understand the movement of cortisol through a body. So a patient last week had a 5-phase cortisol pattern through saliva, and her blood levels looked great. And I was like, I don't believe this. And we could see that she wakes up in a panic of cortisol. Half an hour after waking, she's still in a panic, and then she just crashes and has nothing left for the rest of the day. So that's a completely different picture than what that blood level tells you, because the blood level is just going, do your adrenals function or don't they? Can you actually produce cortisol? Not what do you do with cortisol through the day, and where are your vulnerable points, and where can we implement measurements to actually measures, not measurements, to support you through your 24-hour window. So personally, I will always do blood, urine, and saliva if I can. In a 20-something-year-old, I might just start with blood. But if there's things there and I'm like, something feels a bit fishy, or I don't feel like I'm going to make the most difference, I'll add it. But as a woman gets older, I'll always do the urine and saliva, because as we get older, the way I see the endocrine system is like there's a container of how the endocrine system works beautifully. And then as we get older, all of a
And
sudden
then we turn 40. Yeah.
Or 35, 36,
Yeah.
depending on you and your makeup. But the whole thing is that the doors open, and then you start your bandwidth of what normal is for you starts stretching. So the lows are lower, the highs are higher. And that's where we need to understand what's going on underneath it.
And so for someone who's having a turbulent perimenopausal phase, then let's say, what is the saliva versus the urine versus the blood telling you, and of course the person in the room telling you, that helps you know how you're best going to move forward?
Okay. So the thing that it's a little bit of a long answer, and I'm sorry. The thing
No,
that I
it's
always say
good.
to my
Never
patients,
apologize for one of those.
sorry.
Good.
The thing I always say to patients is I always have 3 hats. So I am a researcher, I am a clinician, and I'm also a human being. The researcher in me wants to test a perimenopausal woman every month, because I want to see exactly what's going on, and I want to know the data, and I want to know this month you do this, and this month you do this, and this month you do that. The clinician me goes, so you have all that data, does it change how you treat them? Probably not. The human in me goes, who the hell wants to test everything every month? It's not going to happen.
Mm.
So in the middle of that, you kind of look at it and you go, at the beginning of treatment, it's definitely a 1 month blood process in the sense of a day 2 and maybe a day 21 if I can. It's always a urine because we need to understand what is and isn't working in your pathways. And the saliva gives me a sense of other aspects to it. I don't tend to use saliva for estrogens that much anymore. I don't find them that accurate, or they don't change how I treat, but the urine changes it dramatically.
Wow.
A big difference, because the thing with perimenopause is there's no regularity to anything. Yeah. We'd love there to be this clear, unified structure of this is what happens here and here and here. But if you get a woman and she's in her estrogen chaos, so estrogen chaos is you started to reduce your ovarian reserve, you started to sometimes ovulate, sometimes not ovulate, and then all of a sudden the estrogen goes, whoa, there's no progesterone to contain us, we're going to do what we want. This is the phase where I always say to perimenopausal women, if you're starting to have like a sexual explorative type of phase of your life, that's your estrogen chaos, because your ovaries are releasing multiple eggs in a month. This is why women in their early 40s
Let's make all the babies.
make all the babies. They have a higher chance of twinning. They kind of go, whoops, we have this baby at 44. What's going on? It's this incredibly fertile time because the body's like, it's your last hurrah, go for it. So to try and get some linearity to that in a test, you got no chance. And what happens with women is they don't have this 28-day structure, or like 28-day structure. They'll be ovulating multiple times in the previous cycle for this cycle. It's just all a bit of a mess. So you get a blood draw and you don't know what you're looking at, because it might be the high estrogen moment, the low estrogen moment. But if you do the urine, you kind of go, well, in amongst all that noise, you still don't process your estrogen well, and you still have a higher chance of toxicity or higher cancer risk or undermethylation of it or whatever it is. That's consistent. So that's where I find it's actually really helpful, because this is where you have conversations of, do you want herbs or nutrients or bioidentical hormones? And I don't let anyone go anywhere near hormones until I know that they've got safe pathways.
And that is what the urinary testing is the most helpful
gives me much more confidence. Gives me the confidence around it. Because blood, honestly, you could literally test them 6 months in a row and get 6 different pictures. 1 month, their FSH is off the charts. They've got no estrogen. The doctor's like, you're about to go through menopause, or you are. The next month, their estrogen is 4,050. And you know what I mean? And their FSH has gone down because it's what is happening. Yeah. Obviously, after estrogen chaos, they start just raising their FSH and things are running out. But so many women come to me and they've been diagnosed as, no, you are menopause. And they're like, hang on a second, that makes no sense. I still feel like I've got estrogen or whatever. It's just the ups and the downs, and they've just been caught on the 1 month of the down.
Wow. Yeah. Oh, gosh.
Does that make sense?
I feel like I want to move into a consult with you, Leah.
Like that another time when we're not recording.
I just had this test. No.
We'll push pause. We'll come back.
So fascinating. And so let's talk about these pathways, because I guarantee you a few people are like, but which pathways and which ones are the worst ones? And, just in case my clinician doesn't know, so I can research and bring it to them.
Yeah.
Could you just expand there?
Yeah, of course. So we call this the sterogenesis pathway. Yeah. So the first thing you've got to be mindful of is that the liver produces cholesterol. Cholesterol, we believe that the human body has, each individual human body has a set point for how much cholesterol they need to survive. Cholesterol is not the devil. It's not the problem. Cholesterol then gets converted into pregnenolone. Pregnenolone that gets converted into a number of pathways, from DHEA to testosterone to the progesterone pathway.
Oh, can I interrupt you there then?
Please.
So could the reason that perimenopausal women experience elevation in cholesterol be the body's way to go, come on, help us make some more pregnenolone and sex hormones?
Yes.
Somebody, please. Is that what's going on?
Yes. So you've got 2 things. So remember my analogy before, which is we have a bandwidth of hormones and then the doors open. Okay. So have that in the back of your mind. So as a woman's going through perimenopause, you've got the E2, which is the estradiol, which is produced by the ovaries, going up and down and up and down, and then eventually down, down, down. And so then the body produces what we refer to as secondary sex hormone synthesis, i.e. that E1 or E3, but predominantly the E3, the estriol. And the estriol is the form of estrogen that a woman uses postmenopausally as best as she can. And so in perimenopause, apart from the fact that she's producing so much E2, as well as all the other E1 and E3, her body is trying to get that secondary sex hormone synthesis up so that after menopause, her body has another mechanism. So for all women, when they're going through peri, cholesterol goes up, but the bandwidth of how high it goes is your genetics. So if your genetics is a strong family history of hypercholesterolemia or high cholesterol, your bandwidth might take your cholesterol to 9 or 10.
Wow.
9 or 10 is obviously not an ideal. That's total cholesterol, not ideal, and increases your risk of cardiovascular event. But your bandwidth might only be to 5, and then you don't really have to think about it. If you're a 9 or 10, the latest research at the moment is calcium scores are the test to do before you entertain the prescription of statins, because this will go down. So you may have a 5-year window where it's a bit up. And if you have lots of fiber and maybe you go on to various supplements or you're exercising and doing things and your cholesterol score is fine. Cholesterol score is basically a CT scan of the heart, and you want to include the neck. If there's no calcium deposits, there are no risks. You can just keep monitoring the cholesterol rather than jumping on a statin, because you need that cholesterol molecule. And remember that the cholesterol molecule is for any steroid hormone, which includes cortisol. So any woman that's perimenopausal, what do we need cortisol for? We need it to just cope with perimenopause, yeah? Because it's a bit of a ride. So if you block cholesterol...
How diplomatic of you, Leah.
It's a ride. Let's be frank. It's a ride.
Yeah, it's a terrifying roller coaster at times. And then sometimes it's that really relaxed little bit at the end where you're pulling into the dock and you're like, oh,
I can do this. Okay. I'm okay. I'm not losing it. We're fine. But yeah, my concern is the women that go on statins when they don't need it, and then they block their cortisol, and then they just don't cope. And
so
no
they're
cortisol,
literally in that case sucking up the last of their sex hormone synthesis. Wow.
Yes. Which then makes it harder for them for their secondary sex hormone synthesis. But I guess it's to be mindful that, you know, mainstream medical model at the moment is don't treat it until you're through menopause rather than prevention. And the thing that my brain always does is that bandwidth idea again. If I can keep the doors closed, then all of my Achilles heels of potential disorders or genetics or risk factors, I'm containing them rather than waiting till I'm at the finish line and seeing all these diseases starting, from bone health to cardiovascular health to all the things.
Wow. It's fascinating to me to hear this as someone who, and I won't say has had, I'm still going through learning about mold toxicity myself, because I haven't reached a point where the resilience piece is back, where I don't react to normal levels in buildings and even household items. I will react massively and in a very inflammatory way. When did it all kick off, though? When I was 40. Interestingly enough, at 40, had a general anesthetic, a surgery, ENT, because I had a leaky tear duct, which of course later was just inflammation from being in a water damaged building. But what was super fascinating, I know your researcher mind is going to love this, is I went from having a slightly irregular 32 to 40 day cycle, kind of, who knows, and really trying to figure it out for ages, to boom, after that GA, 28, 28, 28, my cycle shortened. For the first time in my life, I had a reliable cycle and have had, touch wood, don't go away yet, since. But what's fascinating to me about that is it almost feels like the reset encouraged a perimenopause acceleration, because my entire health just went a bit barney after that. And there are so many women I've spoken to who have similar, maybe it was the epidural in the emergency C, or maybe it was something about the toxic load of an anesthetic. If you're already maybe having a hormone picture that's starting to creep up, or a this or a that, and then boom, you're in some kind of weird overdrive that you find really hard to control. So speaking to that too hard basket, given there are a lot of people in our community that really feel like they find it hard to calm the farm, and the hormones, whether it be thyroid, whether it be sex hormones, seem to all be in pictures of either an autoimmune presentation all of a sudden that you didn't have before, or mold toxicity where, yeah, you might have been susceptible, like gotten a snuffling nose or post-nasal drip, but you never had like a full-on catatonic experience. What is it about our hormones that it sounds like they get involved and act like kind of unnecessarily urgent and hypochondriac messengers for us sometimes? Or
It's a
are
new one.
they,
I like it.
yeah.
Or are they? Sorry, I interrupted
Yeah,
you.
or are they or is it really that urgent and we're just not listening right, and because of our lack of knowledge clinically at this point, and research being far away from where clinic needs to be to help people get well in these more complex situations, like are we I think you understand what I'm trying to say. I don't
I
want to
do.
ramble. Yeah.
No, you'd never ramble. Let me know if I miss it though, if you need me to go in a different
Mm,
direction. But I think the thing to be mindful of with hormones is they're chemical messengers.
mm,
So they are messengers of communication between glands and tissues or organs or systems. And when something intercepts that communication, i.e., general anesthetic or vaccine or illness or infection or mold exposure or major stress, like anything,
mm,
when anything intervenes with that chemical messenger signal, it's all about some substance being picked up by a receptor. So
yeah.
if there's an interference, then they don't find each other. And situations like, if we go back to that perimenopausal thing, it's different in the sense that the usual normality for that woman has to change into a completely different architecture. So
Mm,
when it's a different architectural design, which is the same as puberty if you go backwards, when it's an architectural design piece, the whole orchestration from the brain is what's evolving and what's changing. So then the intercommunication is upgrading as the brain is evolving.
mm,
So it's when it happens at those very key transition points in life, any vulnerability, because the gates are open, any vulnerability sets it off in a way that becomes quite dramatic and changes the course and the direction quite aggressively. So whether or not your cycle when it was 32 to 40 days versus 28 days, I don't know which one your normal was. But
mm.
because it was a change synchronistic to an experience,
Yes.
my instinct says it was where the doors were a bit open, being 40, but that you probably weren't ready to go to that change necessarily. If you can bring it back, obviously ideal, but it's a difficult one because a general anesthetic is a fairly toxic experience for the body.
Mm,
Necessary, but
mm,
toxic. But when you bombard the body with that, if we get really functional about it, general anesthetic trying to be metabolized by the liver manufacturing cholesterol, sterogenesis from there, that interception at that liver level meant the liver went, I'm a bit overwhelmed.
mm,
And the liver and the brain talk every second based on hormone signaling, and they're constantly trying to modify, tweak, adjust based on what we're exposed to. So it's an amazing system of the body, incredibly intricate, incredibly intricate. And you think about the domino thing that I said about before, just having a memory, a smell, a touch, a taste, any sense sets off a whole new cascade of hormones.
mm.
Like we do a
Yeah.
meditation and that hormone levels change. It's incredibly delicate. And that's the thing that I think that we all underestimate.
So to that point, can a big message of positivity, hope, and empowerment
Absolutely.
be,
Yes.
like if we think about Bruce Lipton's work,
Yes.
and could it be that the biology of belief in these doors are open, receptors are a bit off moments be really key to us recognizing how important it is to do that work, whether it be the brain retraining stuff that's turning
Yep.
up, or limbic system techniques and calming and vagus nerve
Yep.
toning. And
Yep.
I feel like it's no accident that chronic illness, I actually sometimes think it's always been there in a massive magnitude. It's just that people got called crazy a lot more often in the
Yeah.
past.
Yeah.
And now that we're talking about that, other people are realizing that their fields of medicine and science and research can help. And we're all talking more. And I don't think it's an accident that it's all starting to connect.
100%. 100%.
Mm,
I mean, this is where, mainstream medicine's dissection of everything is getting more and more problematic because of the
yeah.
interlinkage between everything. But I mean, any of the, I guess when you take a step back and let's say we're talking about you at 40 again, if they're okay, we keep using you as an example.
All good.
At that particular moment, your brain was restructuring itself with all the Lisa Mosconi work, who I know we both love. It was restructuring itself to move towards that postmenopausal brain. My interpretation, it's been like this for a long time, in that restructure, remember Christine Northrup wrote about this 30 years ago, the idea of being,
Exactly. Yes.
externally service oriented versus self-loving. I actually think that all of our different, just to extend on it, all of our different histories, our memories, our traumas, our experiences, whatever, they all come up for us to go, is this going to be part of the new brain that we create?
Mm.
So then all of those positive thought patterns, all of the, the manifestation ideas, the affirmations, whatever it is that you choose to do that resonates for you, it's about the change in how you direct what will be your new bandwidth after that transition. So then
Hmm.
all the hormones come back into it to create new reference ranges for you.
Yeah, brilliant. And reading between the lines of what you've just said, it sounds like you're really giving people agency to discover what aligns for them rather than picking something, seeing someone else talk about something else and then going, oh, I've
Mm,
chosen the wrong thing. That looks like it's better.
mm,
Really tuning in is actually one of the biggest invitations of any tumultuous hormonal time.
100%. But also
Mm.
in the open gate, if we keep using that analogy, in the open gate period, it's the opportunity to also experience the greatest peak and the lowest low of whatever that is for yourself, to discern what it is that you want, but also to understand it in a different way. Like, I don't know
Mm.
about you, but sort of as my brain is going through all of this, I'm understanding everything in such a different way because I'm
Mm.
understanding what those lows were or what those highs were and which bits I want to take and where I want to move the barometer of what my new range will be as I get to the next phase.
Mm.
Because I think it's so much better, no disrespect that I have two sons, but it's so much better than the male model because they don't have such a brain change to what we know yet.
Mm. Yeah, it's almost like for men and boys, they have to blow everything up to put it back together again. But we're actually literally forced to blow everything up and put it back together again. So it's actually part of our process, that kind of,
Mm, mm.
wow, it's all changing and how do I want it to be for the next
Yeah,
chapter?
yeah,
They're like,
yeah,
oh God, nothing's changing. And do I want it to stay the same?
yeah.
That's actually in many ways a harder journey.
Much harder, much harder.
Mm. Poor
Mm.
boys. We've all got our ups and our pros and
We've got our
cons.
challenges.
Yeah, there you go.
Yeah.
Okay, so can we talk about testing in different situations
Hmm.
and different clinical presentations so that
Yep.
we can kind of grab a few different groups of people having various issues or concerns at the moment. Puberty.
Hmm.
Let's go with girls and like big highs and lows in mood and
Hmm.
super heavy periods
Hmm.
with a bit of acne. Now, when I was going through school in the late 80s, I would have been in my mid-teens, and that was popper on the pill. And I remember like three of my friends who had that clinical presentation were put on the pill
Mm.
to fix it. Now, what kind of testing could we be doing instead that gives us a more complete picture of what's going on?
Mm. Similarly to the perimenopausal woman, you've got a brain that's changing. So,
Mm.
because the brain is changing, we know the research at the moment is suggesting that it takes 2 to 4 years for the brain ovarian axis to create their communication appropriately, which means that if any of your friends, for example, in those first 2 years may have given skewed results if you did a test on them, and it may
Mm.
not have actually been the clarity that was needed. I do think that some people, they sort of have genetics where it takes them longer or shorter, and you can look at people's body weight distribution to give you an indication of speed. So generally, the very thin, tall people up and down long curves, they take a longer period for the brain and ovarian axis to develop that real tight network of communication
Mm.
versus people that have more curvaceous estrogen types. They do it a bit quicker because there's so much estrogen there. So that's why the body increases fat distribution in anticipation of puberty, so that it can use that fat to signal and carry the hormones around. So that can be helpful. But in those situations, if that girl is not on the pill yet, you'll get obviously much more accuracy, but you often won't get a clear picture because she's too young. And that goes for insulin, it goes for thyroid, it goes for everything. Like I've got, you sort of go through waves of types of people that you see, and I've got a batch of these 13, 14, 15-year-old girls that have periods and then all of a sudden have nothing for like 2 years. And the endocrinologists refer them to me and they go, what's going on? And we're looking at their insulin levels or their thyroid, and we're looking at all the other endocrine glands, getting them all happy, and then their cycle comes back and it's fine. So it's so much in that instance where a blood level will probably send you on the wrong pathway if you don't look broad enough, but also don't jump up and down and assume that that blood level means everything because it's so changeable.
Yeah, wow. And
Yeah.
so would that particular case scenario be more about really listening for what the person's experiencing? And
Yep.
like, again, you wouldn't, I mean, maybe I don't want to judge people who really do find that the end solution is the pill and that's their SOS
For
while
sure.
they
Yep,
long
that's fine.
game explore, other
Yep.
options. I always want to be really mindful of that. But what would then be some of the things that you would do in that situation?
So this is where, and shut me up if I'm going on a tangent that you don't
All
want to
good.
go to.
I love
So
tangents.
good, good. Just wait, you haven't heard it yet. No, I'm kidding. So one of the
Wrong
things that
time to have a sip of tea.
sorry.
All good.
One of the areas that I find really fascinating is the idea of hormonal changes to the microbiome.
Mm,
So if you take one end of the spectrum, you take the puberty girl versus the perimenopausal menopausal woman. So the easier one is the menopausal woman. So she's there and it's all winding down. And so too is her estrobolome or her estrogen metabolism through her gut microbiome changing. And this is one of the reasons why women lose hair, because their hair microbiome is changing, why they lose collagen in the skin because their skin microbiome is changing. Like all of it comes back to their gut function and how they assimilate and digest food. Similarly, on the other end, you've got the pubescent or puberty aged female. Her gut microbiome is changing from a pediatric microbiome into a woman's microbiome. And the acne is often a reflection of her poor metabolism of the estrogen surges as she's trying to work out what the hell is all these hormones and what do I do with it. And the
mm,
thing we've got to be mindful of is that the gut microbiome directs the microbiomes in every other area of the body,
mm-hmm,
from your eyeball to your ear to your hair, but also to the entire peritoneal cavity of the abdomen. So every reproductive organ has its own individual subset of species within the microbiome, and the gut microbiome directs and tells the species what should be there and shouldn't be there based on where we're at with research now, but also clinically. And so, for example, the microbiome within her uterus may not be robust enough to be able to tolerate the changes of a lining growing and shedding and that sort of stuff. So fixing her gut will actually help things a lot. If you then extend that and go, okay, so she's been put on the pill because it's socially difficult, because it's, she's profusely bleeding and staining everything
mm,
for whatever reason was appropriate. We have data that shows that a girl on the pill, when it's too early, her amygdala shape, both sides, the shape of it, the size of it is different, which means her fear receptors and her brain development is different, which means who she is and how she interacts with the world is different. We
mm.
have studies that show that a woman that's on the pill, her attraction to someone is different
Yeah,
based on
that's
if she's on the pill, off the
fascinating.
pill. So there's all of these psychological things that are developing that are probably gut microbiome related. And we know that species are vastly different to a woman that's on the pill versus off. So it doesn't mean straight away rip her off the pill. It means really work on the gut, really work on optimizing particular species to protect against some of the pathways. Because if that's the choice and that's what she needs, then work with it. But fundamentally, her brain needs to get used to her own estrogen, her own progesterone. It needs to mature, it needs to learn the ebbs and the flows. And do remember that the menstrual bleed in inverted commas on the pill is not a menstrual bleed, it's a breakthrough bleed. The hormones that they're on are synthetic versions that will never fit the receptor sites in the same way. So her body is exposed to synthetic molecules that will achieve some things but won't mature it in the way that it could. And we just don't have long-term studies yet. We don't
Mm,
have long-term studies that go, a woman that's on the pill, what's her perimenopause like? What's her menstruating years like? What are the long-term effects of her emotional well-being? We just don't know. Again,
mm.
not the worst thing you can ever do, not shaming anyone, but just think these things through.
Yeah, absolutely. And so then you mentioned it's never going to be the same receptor communication on the pill. Is that why so many people in perimenopause go on the pill in a last-ditched effort of just quietening every receptor down? Like, does it
Yeah,
literally blunt the experience, and that's kind of the allure of doing it at that stage in your life?
100%. I mean, women
Wow.
do it because it shuts down the process so they don't get the ups and the downs. And again, this is not a shaming or judgmental thing, but their experience of their bandwidth is dulled. So they can't know because they're not feeling anything. Like literally, the intention of the pill is to downregulate and suppress the hormonal changes and to give you a synthetic version. I'm fine for hormones, but I'd love it to be the hormone molecule that your body knows, so at least you don't miss out on the gifts of that hormone. Because ask any woman that's on the pill, she does not feel the same way in herself, about the world, her perception of everything. And again, no shame, totally respect people's decisions, but it's a completely different experience of existence. So particularly with perimenopause, all the things that we spoke about just before, if she could work with someone and be given some bioidentical hormones, because remember the pill is progestin, not progesterone,
Mm,
for example. So progesterone as a hormone, it soothes us, it
mm,
makes us recover, it makes us be confident in an introspective, independent experience of our existence. Whereas estrogen is about connection, it's about kindness, it's about giving to other people. And when you don't feel the movement of both of them, and you don't understand that the ups and the downs of your menstruating years moves into a consistency of it, the consistency is another gift of interaction with the world. But the pill then just basically shuts it all off and then leaves you on the other end. And most of those women that were on the pill and then at the end of menopause, they're really lost. They really don't know who they've turned into. And so it's a
mm.
really interesting journey for them.
Ugh.
Difficult for most.
I can literally feel the story of one of my closest girlfriends as you say
Yeah.
that, who's
Yeah.
54. Wow.
Yeah. My heart hurts
Oh,
for them because they,
mm,
you know, that as much as our hormones can be challenging, yeah, that's probably the
mm.
nicest
Oh,
word.
yeah. Mm-hmm.
They can be challenging. They help us learn our capacity and our resilience.
Mm,
And the women where it gets shut off, and it's the same as women that go through IVF, where they've felt like they've been shut off, and then they're pregnant, and then they've got a baby in their arms, and then they're like, "What who am I? What is going on here?"
mm.
It's the idea that remembering that they're chemical messengers of processes.
Yeah. Oh, need a deep breath after that little section.
Sorry, I warned you. There was a little segue.
There was a little segue there.
Mm,
And okay, something that a lot of women experience, it seems to be rife. And I had the beautiful, I'm going to try not to get a lump in my throat when I say her name, Beth O'Hara, on my show
mm,
a couple of times over the years. And she passed away recently from suicide. And what I want to say to speak to her incredible body of work, really lifting the lid on the conversation around histamine issues,
mm,
mast cell activation, and what I almost feel like she was about to jump into a lot more, given her age, was this overlap in
yeah,
late stages of being an ovulating person, how it seems to, during the chaos years,
yeah,
really be chaotic,
yeah,
and the psychological ramifications of histamine being a bit out of control, with estrogen being a bit out of control, must be huge clinical things that you see so often.
very much.
Can we offer some comfort and empowerment, either through better testing, better conversations with health professionals, for the people who are feeling like, why do I have to take freaking Telfast half my cycle now? And,
Yeah,
because
yeah,
that's awful for the gut as well.
yeah,
But so many people are lost in that category, Leah.
100%. There's three parts to that one. So, well, four really, but let's start with three. So the first would be around histamine being a neurotransmitter. Yeah.
Mm,
So recognizing the importance of the personality influence that it provides, positive and negative. Recognizing that histamine interacts with estrogen. So when estrogen is high, histamine is higher. but also recognize that histamine is generally in response to something, which is generally an infection or mold or a toxicity or something along those lines that is setting that pathway off, which means the immune system is then mediated and directed by it, which then means that the identification of what was triggering or is triggering is super important, which then also comes back to the gut microbiome again. So the challenge of the chaos of estrogen is multicellular and multi-system, and underestimating how much impact it has on women. And again, I don't know Beth personally. Generally, I will see women where their mood is that low, and it is because of the chaos, because the estrogen is just growing everything. Because estrogen is a growth hormone, it's an expansive growth hormone. And so, if someone has a gut pathogen, or they've got candida, or they've got any form of growth or infection, it will be worse as the estrogen goes up each time. So you ideally want to enter perimenopause with all of the infection aspects of your body addressed, so that you can just get the positives of it and moderate against it. But remember that estrogen and progesterone always work together. And so when estrogen goes chaotic, if you don't have progesterone there to oppose it, estrogen goes, ha ha, I've escaped the gates, basically.
Yeah.
So progesterone comes and goes, come back down. And estrogen goes, no, 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 I want to go higher. And progesterone goes, no, 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 come back down.
Bad
And so,
idea, sweetheart. Off the
you know what I mean?
ledge.
Bad
Yeah.
idea, come back. And so progesterone is always the one that brings estrogen back into, no, 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 these are our gates. These are our bandwidth extremes. Don't go too far out there. So the first thing when women have histamine and they're in that life phase is progesterone. It's not going to fix the driver, but at least it's going to dampen down the intensity of it, so that you can start to get that the bandwidth just narrows enough so you can see some clarity. And then you can go, okay, what's actually pushing this estrogen up? Is it just ovarian stuff? Or as the ovary is releasing multiple follicles, is the ovarian follicular fluid actually full of some sort of virus or some infection or mold or whatever? And that's what's driving it.
It certainly checks out with my experience of living in a water damaged building and
Yeah, it's
how
huge.
hectic that time was. I mean,
Yeah.
and I remember I was the one who explained to my naturopath, it is at this point in my cycle and this point in my cycle that it all goes crazy. So it seems to be related to estrogen. And she looked into it and she's like, oh my God, there is a connection. Because this was 8 years ago, and it really is very new science for us to be even talking about this. So I feel incredibly hopeful for this next chapter where, people can find answers much more quickly than me digging in chat forums 8 years ago at 3 a.m. going, I gotta find something. I know I'll find something, and then finding it.
Yeah, for sure.
Wow. Fascinating. Okay. So let's talk about budget, because that is obviously a very real concern. As we record this, we've also got the cost of living. So many things have gone up, and yet salaries and wages and small business have not necessarily. And so people are more mindful, but we obviously still want to support people in the best way possible. How can we get the most bang for our buck? If a clinician says to us, I want to do all of this testing and it's going to be, $1,000, how can we feel empowered to say, could we just start with maybe X, based on what you recommend might be the most bang for buck to start with?
Okay. I think the cheapest is they can start doing tracking
Mm-hmm.
themselves. So symptothermal methods, so tracking their temperature, cervical fluid, and their menstrual cycle details, and starting to see patterns, and starting to understand when cervical fluid is increasing, it's likely that that means that estrogen has gone up, which likely means a follicle will be released. So that should be a predictor of ovulation, and confirming that with temperature. And there's no cost to that. Next level would be whether or not they want to do other methods themselves, like urine testing to confirm ovulation if they're cycling, and or any of the newer devices like Mirror and things like that. There are aspects of them that are accurate, aspects of them that are confusing, and trying to understand them. The greatest challenge of all of those is time, because you need 3, 4, 5, 6 cycles to really start to understand what's going on. So if you've got time on your side and limited funds, start there.
Mm-hmm.
Your next would be to go to a GP. They may or may not look at the breadth and detail of hormones. You're within your rights to request what it is that you would like. Whether or not they see the justification or understand it, that's going to be the challenge. There are lots of different options from a sort of a Medicare GP grade, and starting there should technically be at no cost to you or nominal cost to you.
Mm.
Beyond that, you're starting to go into, I want to look at every hormone, and then I want to look at every hormone and every different delivery. It starts getting expensive. So, Dutch or the dried urine testing, different labs are better than others, saliva, things like that. You're looking at somewhere around $500, but up to 900, depending on how much you're wanting to go into it. But definitely don't be doing that on your own without having someone help you, because otherwise it's just information that you're not going to be able to use very well. And generally, you could just do that. Beyond that, though, you're looking at things that influence hormone pathways, and that's when it starts to blow out. So, depending on how
Mm.
much you want to go down, you might want to look at methylation testing, for example, to understand your metabolism of hormones, or you might want to look at microbiome and things like that. But starting just from a hormonal perspective, that's probably, your zero cost to high cost, and then you could go from there.
Yeah, nice. Oh, and so last question.
Sorry.
No, but it's just good to know what all the different levels are. And I really
Mm,
appreciated that you started with something completely free. Like a
mm,
lot of people book a clinician and start with a clinical conversation, whereas that clinical conversation is going to be way more useful if you've done some free GP hormone testing
yeah,
and you've done some symptom and cycle tracking
yeah,
and just book your thing like in a couple of months. Obviously not in an SOS
for sure,
situation. I
for
mean, you'd
sure.
be going to ER in an actual SOS. But
Yeah,
sometimes some of us just feel super crappy, but we've kind of gotten used to feeling super crappy. So what's another month?
pretty
And
much.
so then you're bringing information instead of bringing I feel awful. What can I do? And then the whole session is on questions that you haven't actually collected answers to yet. Would you say that
100%.
that's a really good way to start feeling a bit more empowered?
Yeah, but also know that you know your body better than anybody.
Mm,
You're in your skin, you're there month after month, seeing the changes and just starting to get a sense like you hunted through the chat forums and stuff. You knew something was wrong, you knew exactly when it was happening. You just had to work out what the answer was. Had you seen a clinician at that time, you had a clinician though, maybe having that conversation that she could have pieced it together with you as you discussed, but then you showed her what it was because you'd done the searching. We know our bodies really well. We know when something feels off. Every woman on the planet knows when perimenopause starts. She may not
mm.
want to admit it, but she knows it.
Well, yes, she knows something's up, but thanks to being largely kept in the dark on women's health situations, it's usually a few years into it where you're like, okay,
Yeah.
so now I'm on the ADHD meds, the anxiety meds, I've had
Something's amiss here.
something's not quite right. I never used to have to deal with all of this stuff. Yeah, it's so true.
Mm.
Um, a message of hope around hormones. Would you like to leave us with
Sure.
some
Something uplifting.
interesting, yeah, something uplifting? I feel like, that's where we need to finish.
Yeah, no, absolutely. There's two parts to it. One is if we go back to the idea of our state of mind influences our hormones. We've
Mm,
got enough research to show that someone that meditates or does breathing exercises or listens to frequency patterns or is in nature of something that resonates for them, hearing the ocean waves crash or something like that, we literally will change every single one of our hormones. So nature provides a lot for us and we absorb things through every sense and it will direct it, but equally, we change our hormones through human connection. So
mm,
when we have a beautiful experience with someone, be it platonic, sexual, romantic, our children, whatever it might be, oxytocin is like the balm for every hormone cascade. Don't underestimate it. You just get a really good hug from someone, and it's like your hormones calm down because they often at times start to scream at us to get a message across. And sometimes they just need that balm of oxytocin. And it's fascinating. I've done a few talks in the last year just looking at oxytocin in different hormone pathways. And it still always comes back to the same thing. We release endorphins when our oxytocin is high. We achieve good levels of oxytocin through human contact.
hmm. Our bodies are screaming out for a hug.
Basically, that's I think
That
where we leave it. Yes. It's basically what it is.
We're
We are all
complicated
needed.
plants. We're
We're complicated that
complicated
just want love.
plants that need love and hugs and the
Yeah.
occasional glass of water. I love
Yeah,
it.
maybe.
Okay.
Maybe.
Yeah. Thank you so much, Leah. Always a pleasure. I always get
Thank
so
you.
much out of chatting with you and bringing these amazing insights to our community. I appreciate you.
Thank you so much. Thanks for having me.
I hope you loved today's show as much as I loved bringing it to you. I want to remind you that if you are someone who craves a low tox community that is judgment free, full of empowerment, has health professionals and building health professionals that can support you, as well as me in there answering questions multiple times a week, I want to invite you to join the Low Tox Club. For the price of less than a cup of coffee a month, you have an annual membership for $49 Australian, so it's about $30 US or euro, that allows you to have a member masterclass every single month with a health professional or global expert from the podcast, where we have them to ourselves for an hour to ask questions and deep dive further. You have the beautiful supportive chat group. You have Q&As with me answering questions. We read books and talk about them, and a whole bunch more. You can head to lowtoxlife.com, hit the explore tab, and join the club is the very first option on that list. Of course, we have over 10 evergreen courses that you can jump into anytime, whether it's navigating everyday low tox swaps with our Go Low Tox signature course, whether you have kids and you're wanting to know how to best support them with our Low Tox Kids course, whether you're planning a family and looking at a healthy low tox preconception journey, reducing inflammation, especially the chronic kind, with our Inflammation Ninja course, many other courses. You can again head to lowtoxlife.com, hit the courses tab, and you'll see all of the options, which includes a business course, my Low Tox Method program. A lot of people don't know, but I was doing a lot before starting Low Tox Life in 2009, and I was a business consultant across hospitality, health, retail, and cosmetics. I have been in business consulting for a very long time, so I absolutely adore helping people move into the low tox space or develop their low tox businesses. So that's a way I can support you. And then, of course, there's our wonderful social media communities at Low Tox Life on Instagram, and of course, the website with over 250 gluten-free recipes, blogs, downloadable PDFs to help you navigate wanting to get rid of synthetic fragrances in your school or office. I could go on. So head to lowtoxlife.com, see what takes your interest or fancy, and thank you so much for being a part of our podcast community. I love reading your reviews. I appreciate every follow and subscribe, and I want to just remind you to finish off that if there's anything you heard that you found interesting from a medical or scientific perspective, it is intended as education only. Please always chat to a health professional who knows you and your situation best. I'll see you next week. Bye.